VMR, and today I get to discuss with Rabih a case, and it's actually, I mean, it's always special because it's a Thursday VMR, but it's especially special today because we have Umaima, who's going to present a case today. And it's the first time she's presenting here on VMR, and we're super excited and very grateful that she takes the time to present today. So Umaima, do you just want to say hi and tell people who you are?
Yes, thank you, Leia. Hi, everyone. My name is Umaima. I'm a final year medical student from Morocco and the new CPS CP Solvers team member. I'm so happy to be presenting my first case today. I've been procrastinating this for months. Yes, I'm very glad I'm finally doing it. And it has nothing to do with AIDS, by the way. That's not a hint of what the case will be about.
Amazing. It's a delight to have you here. I have to pinch myself to be like, wait, what? We're discussing with a trainee in Austria and a presenter in Morocco. It's unbelievably crazy. It was people all over the world hanging out here. So thank you all for joining. Umaima, how are the nerves right now? Out of 10, how would you rate them?
10.
10, huh? Why do you think that is?
I study medicine in French in Morocco, and even when presenting in French, I find it kind of challenging, and I stutter a little bit. So doing it in English in front of this amazing, smart, accomplished audience is a little bit intimidating, but I hope I will get comfortable by the end of it.
Yeah, no, it's unbelievably intimidating. I think we were having a similar conversation with Jas, who was presenting 2 weeks ago now. And I think it says so much about somebody who's willing to fight that battle, and fight that battle publicly, because it's not an easy one. And so kudos to you for jumping the language barriers, the inherent video stare barriers. And I think this hierarchy in medicine about this idea that everything must be perfect and we must present perfectly. So thank you for publicly doing that in front of all of us. I think no matter what it does for you, and that's always, as Laura was telling us beforehand, that's always hard to predict, honestly. But I think what it certainly does for everybody else is it shows them that their battle isn't something that they're fighting by themselves, that it's actually something that's universal, and that it gives all the rest of the crowd a little bit of a nudge to fight the demons that we all face within medicine. So thank you at a bare minimum for that. All right, let's take it away.
All right, so today we have a 37-year-old male who came to the ED, who was brought to the ED by his brother with jaundice and confusion. His brother reports that the patient started presenting with jaundice over a week ago, and over a few hours ago, he started becoming confused. He didn't know who his brother was, where he was, so he brought him to the ED. His brother also reports that over a week ago, he had a fever and rhinitis, for which he took acetaminophen and over-the-counter decongestants.
Okay, so
Shall I go on?
I think I can say my first thoughts here, and then we go on with the next part. Thank you. Okay, so confusion and jaundice with a 37, so still relatively young middle-aged male. I think I had several thoughts when I heard this. Of course, okay, should I just look at jaundice as a general symptom and then think about what I know about jaundice? But here we have I think what is interesting, the time course as well, and what will change a lot how I think about this is knowing more about the background of the patient. So knowing, is there any past medical history that could relate to this, or is this just something that happened out of the blue and now we have to figure it out with this information that we have right now? But it seems like it's relatively acute, subacute, so relatively acute in onset for jaundice, I would say. And and it seems like confusion preceded the jaundice. Now I wonder, did the fever and taking the medicine, was that before the jaundice as well? Because then I might think of something like a medication-induced liver injury. And then in general, I would want to know, okay, what kind of jaundice is this? Is this direct or indirect bilirubinemia? And then also with the LFTs, is it more cholestatic or hepatocellular? And also with the confusion, I was wondering, is this hepatic encephalopathy that comes from this, I presume, acute liver injury, because I don't know about the past medical history? Or is there something else to it? But I think, especially with this patient, the labs would be very helpful, because if he doesn't have any past medical history, the physical exam probably will not be that helpful. I don't know. Yeah.
Well, yeah, I think that was absolutely superb. I have nothing to add. I'm just going to try to reflect with you on one dimension, which is trying to predict the next step. So based on your analysis, what would you predict the jaundice will be? Do you anticipate it to be more likely direct, or do you anticipate it to be more likely indirect? What do you think?
It's a good question. I think intuitively I would say more direct, just because indirect I associate with hemolysis, and I don't see any other signs for that, or I would expect him to be more ill if this was really hemolysis so extreme causing jaundice. And this has been going on for a week, so I would say direct is probably what I would predict.
I completely agree with you. I think you can definitely make an argument for why patients with hemolysis might get confused, and why patients with hepatic diseases, the two H's of jaundice, might also be confused. However, I think your mind is wisely applying a law of proportionality and saying, gosh, if the hemolysis were this bad, causing confusion, why is the patient not manifesting with some sort of cardiopulmonary deficiency? It's almost impossible for hemolysis to beget so much brain issue without first passing through the heart and the lungs. But in stark contrast, the liver almost always spares the heart and lungs in many circumstances and disproportionately affects the brain. And so I think you can start to assume that this is going to be direct, and pay attention to the medical history with that as your default assumption. And the difference between an assumption and bias is to lock in that assumption. So you definitely have to humbly accept that the lab will outperform our prediction. But it's a good idea to have a working hypothesis, because you'll be able to make more inferences based on the data rather than pretending like you're neutral. We're not neutral. I would say this is 95% going to be direct and 5% indirect. And when it is indirect, we'll learn about what we missed along the way that might have clued us in. All right, Umayma, tell us more, please.
So our patient does not have any prior medical history. He's not on any meds, and his family history is only positive for hypertension in his mom. And he doesn't have any allergies. For the vitals, he has a blood pressure of 140/90, a pulse of 128. His temperature is 37.4, and his SpO2 is 99%. For the physical, the patient appears uncomfortable, confused, and deeply jaundiced. His respiratory exam is unremarkable. On the abdominal exam, there is no right upper quadrant tenderness, there is no tenderness or right upper quadrant pain. For the cardiovascular exam, it is normal, other than him being tachycardic. For the neuro exam, he's not oriented in any domain and could not follow comments. And his confusion really limited the physical exam. And there is no rash.
While Leah is thinking, I can see she's thinking, I just want to say, Umayma, you have us on the edge of our seats. This is an incredibly polished presentation, so well delivered. Thank you. I can't wait to get your take on what you were thinking when this case was evolving, but we'll lean on Leah now to share her thoughts.
Yeah. So I think with this not being this patient not having any past medical history, it's kind of, as we predicted, okay, this is a previously healthy young male who now acutely presents with jaundice. One question that I would have is, did he take the medication before he presented with jaundice or after?
The jaundice was after.
After he took the medication, because then I think it's still quite possible that he took too many of these, or that the medication in itself caused DILI, so drug-induced liver injury. And generally now, before we have the labs or the physical exam, we didn't get much new information. He didn't have left upper quadrant or right, should this be right upper quadrant tenderness? But
Right.
still, it wouldn't, like when I think of the liver, I think I learned that what hurts actually, because the liver itself doesn't have any nociceptors, so it's actually the capsule. So it doesn't exclude anything in the liver happening just because it's not tender on the physical exam. And without any signs of hepatomegaly, also this would be, or suggests maybe this is more of an acute process. Although of course the physical exam is not perfect. But other than that, I'm just looking at the exam. Yeah, now I think I'm more interested in the labs and knowing, okay, if this is an acute onset, I have a few things that I like to think of as causing acute liver injury. So you can think of the parenchyma and then also the plumbing. So plumbing would be like congestive hepatopathy, or maybe the Budd-Chiari syndrome, and then the parenchyma. So viral hepatitis could present like this acutely. We could have drug-induced liver injury, autoimmune hepatitis, which was actually one of the cases that I got to discuss once. Wilson's can also present quite acutely and also with neurologic symptoms. And I think I would want to know how high the LFTs are, because that can also give us clues, because there are some things that give really high marks or parameters. And I think before that, I would also want to ask the patient how much of the medication he took, because that could be an easy way to figure out if this is really something to consider for this patient, or if you took any other medications that we don't know of.
I love it, Leah. I think you're demonstrating how powerful your hypothesis generation is when you're assuming that it's direct, right? We're like assuming it's direct. And so you're saying, hey, what are the most common causes of acute liver failure, and emphasizing the role of the medication that's playing here, especially when that medication is acetaminophen. And I think that what you can say with high degree of confidence is this patient does not have chronic liver disease. And that you may ask yourself, well, what is the value of the physical exam in a patient with jaundice? Like, what is it? What is the role of the physical exam? And I think the most powerful thing to quickly establish is to say, is there evidence of chronicity? Because many patients with chronic liver disease present acutely because of the loss of their reserve. Most patients with cirrhosis come in acutely with acute jaundice, not having noticed long-standing liver issues. And I think the lack of distension and the lack of the cutaneous stigmata of chronic liver disease confirms that the time course is what the patient has noticed it to be. And so I think that's the main value. And now we have to reflect on the fact that the only powerful clue is severe tachycardia. And this is a heart rate of 130. It's not a heart rate of 90 or 105. And so the first thing is to make sure that it's sinus, because if it's AFib, for example, that would be very, very intriguing and would take us in a different way. But I'll just share this observation, which is not evidence-based at all, but certainly an observation. When patients are tachycardic from their liver disease, that changes my calculus significantly, because most people with intraparenchymal liver disease in the liver itself usually do not have a prominent systemic response. If you ask yourself, what is the base rate of tachycardia and drug-induced liver injury and viral hepatitis, I don't think it's that high. It is really a liver predominant disease process. And so what does the tachycardia do? It makes me worry about the possibility of extrahepatic disease complicated by cholangitis. So at the end of the day, if you look at this patient meets all the criteria for cholangitis. He had a fever, he's confused, he's jaundiced, and he's tachycardic. So for me, I'm a little bit more worried now than I was before about an extrahepatic issue. But I have to tell you, when you see these findings, you have to think about a non-hemolytic cause of indirect hyperbilirubinemia. So let's step back for a second. when we're thinking about jaundice, we're thinking, is it prehepatic, which is indirect hyperbilirubinemia? Is it hepatic, which is in the liver, or is it posthepatic in the biliary system? And you and I equated the idea of indirect to hemolysis, but that's not 100% true. There's another systemic issue that can cause indirect hyperbilirubinemia, and that's hyperthyroidism. And so in a patient who is young, who is presenting with jaundice, tachycardia, confusion, the possibility of thyroid storm is something that is never going to be likely, but it crosses the threshold to make sure you send a TSH on this patient. Unlikely, but important to rule out. So I think probabilistically what's happened is I think you have to mandate an evaluation for extrahepatic disease given the fever, and the money is still on direct, but it has shifted a little bit more towards making sure we haven't missed or aren't missing thyroid storm here, which would show up in this way. All right, Umayma, tell us more, please.
Okay, so I'll start with the hematology labs. The white blood white blood cells count is 20. The hemoglobin is 4.9, and the platelets is 6. Shall I give you the other labs, or do you want to discuss it
Why don't you
first?
go for it just for the sake of time?
Okay.
But I think you totally should have stopped there and just for the power of this data. Thank you.
His sodium levels are normal. Potassium is 5.7. Creatinine is 1.9. And glucose is 147. The AST and ALT are in the teens.
Okay, could you maybe say one more time for the AST and ALT? I don't think I understood.
I think 15, 16, I don't remember, but they were in the teens.
And remember, just for the sake of time, I think since we only have 10 minutes left, do you have the bilirubin, the total, and the direct?
Yes, I do.
Thank
So
you.
the total bilirubin is 8.1. The direct bilirubin is 3.7. Shall I give you the LDH and haptoglobin too?
Yeah, go for it.
Okay, so the haptoglobin is 7 and LDH is 3,000.
Thank you.
Okay, so we have a lot of labs here, or a lot of interesting labs. So we could have totally stopped after the first 3, but there is marked anemia. We have thrombocytopenia, leukocytosis, and then as I'm looking, we have parameters that are consistent with hemolysis. So we have elevated LDH and decreased haptoglobin, if I interpret the values here correctly. And also, it seems like a big component of indirect bilirubin that is elevated, and which is quite surprising because that's not at all what I expected. And I think what makes me worry here is, okay, so now I'm thinking, okay, could this be thyroid storm? Actually, I didn't know that it was a cause for indirect hyperbilirubinemia, but now does a thyroid storm also cause thrombocytopenia like this? I don't know the answer for that. I would have to ask. And then the potassium being high is also consistent with hemolysis. And we have this cytopenia, so hemoglobin and platelets being low, which can have many different causes as well. I was wondering, okay, could it be a septic cause? Could it be which is, to me, this is too marked for it to be just sepsis induced, and also there is no fever. And I noticed that I'm jumping around in my thoughts at the moment, but to not talk too long because of time. I'm wondering, okay, if this is this still consistent with thyroid storm? I don't know, because of the platelets. I have a knowledge gap there as well. And then I'm wondering, okay, if this is not consistent with that, what causes could cause both lower levels of hemoglobin and platelets? Could it be a MAHA? Could it be a destruction problem of both of them? But what is most likely here, I'm not sure. And then because cholangitis was also mentioned before, I think because of the LFTs and yeah, it becomes less likely. So now it seems like there's not much injury in the liver, but actually we're dealing with a hemolytic cause, or I shouldn't say hemolytic, but yeah, maybe hemolytic, and then another, because of the parameters, cause of jaundice in this patient. And I would pass on to Rabih because I think I have to gather my thoughts to say something else about the causes for this indirect bilirubin.
Yeah, you know what happens is these cases are how people tear their ACL, because you're running and you're running and you're running and you're running and everything is screaming directly bilirubin. Then all of a sudden, Umayma drops this incredible piece of data that forces you to stop in your tracks, twist, and almost break your leg. But we won't do that today because I think you're exactly on the right track. I think at the end of the day, you step back and you check your default assumption. Only less than 50% of the bilirubin is direct. This is an indirect hyperbilirubinemia. And then the case for indirect hyperbilirubinemia is augmented by the context. And the context is that you have an acute anemia. How do you know it's acute? Well, the patient's tachycardic, right? Patients with chronic anemia aren't usually tachycardic. So you have an acute anemia. And now you layer onto that, you actually don't just have an acute anemia, you have an acute bicytopenia, you have acute anemia and thrombocytopenia. So the question is, what causes simultaneous anemia and thrombocytopenia? And I will tell you the truth. The first is you have to make sure that they aren't causing each other. A patient with thrombocytopenia can bleed, and a patient with a chronic hemolytic anemia can make their spleen big and sequester their platelets. So they don't have to be caused by something in common. They can actually cause each other. But it's much more likely, given the acuity of the syndrome, that they're caused by the same thing. And that really only occurs from one of three things that unites them. What unites them? The environment in the blood that they're in, and that environment can become dysfunctional, and that's what causes a microangiopathic, i.e. blood hemolytic anemia. So that what can happen also to both of them is they can both be attacked by antibodies in simultaneous autoimmune hemolytic anemia and immune thrombocytopenia. That's called Evans syndrome. The final thing that they have in common is the most common explanation of anemia and thrombocytopenia, which is that they have a bone marrow issue. And that bone marrow issue is usually augmented by the presence of a leukopenia. But remember, this is Umayma and her masterclass presentation. We don't know that this white count is neutrophilic. If Umayma tells us in the next second that these 20,000 cells are all blasts, then all of a sudden we have a very clear answer. We have a patient, a young man who has acute leukemia, which is not unheard of, who has intramedullary hemolysis in the bone marrow. So what is key right now? The key is to say it's one of these three things. Is it a microangiopathic hemolytic anemia? Is it an autoimmune hemolytic anemia? Or is it a bone marrow issue? And the peripheral smear will likely tell you the answer. If it's MAHA, you'll see schistocytes. If it's Evans syndrome, you'll probably see spherocytes. And if it's one of the worst case scenarios, you'll probably see blasts. So the peripheral smear will very likely unlock this case. But in the face of confusion, I think that the operating hypothesis probably has to be the champion of all MAHAs, which is TTP. So that would be an operating hypothesis, but you need the smear to make sure that you can proceed to the next steps if that bears out. Any other thoughts, Leah, now that you've had a chance to collect yourself and think about this more?
No, I think I also was thinking about TTP just because neurologic symptoms are more common with that MAHA versus the other one. But no other thoughts. I'm curious to see what Umayma has in store.
I have two more labs. The first one is the smear. On the smear, there were no blasts and there were schistocytes indeed. And I have one extra lab. Should I give it away, or do you want to like discuss the case further?
Now that you've given us the schistocytes, I think it's a great opportunity for Leah to stretch her MAHA skills. So take it away, my friend.
So I think schistocytes is something that would really support this hypothesis of MAHA. And the differential diagnosis for schistocytes that I know of is it could be DIC, it could also be a production problem like a B12 deficiency, or hypertension, or something like a heart valve that is mechanic heart valve, or endocarditis that destroys it, so it's mechanical destruction. These could all cause schistocytes as well. I think in this context, it's very telling or very supportive of this being a MAHA. And maybe perhaps the next test would be an ADAM-TS13 that would support this hypothesis. Although I think the test takes quite a long time to come back, so we would have to treat the patient before the ADAM-TS13 would be back. And now this I don't know because I've never been in the clinical setting, but I think there is a score where you can see if the clinical probability, how high that is, and definitely treat the patient because otherwise this could be very fatal.
Absolutely superb, my friend. I think you're on the right track. I think that you have to assume that this is TTP until proven otherwise. But I think you also share with us the importance of having a checklist for other things that can look like it. And that checklist, sometimes you need advanced testing for. You need advanced testing to look for HUS. You need advanced testing to look for APLS. You can need advanced testing for some of the genetic diseases that can do this. But I think the initial thoughts are to ask things that you should know, and we do know already, which is the patient pregnant? Because this could be preeclampsia or eclampsia spectrum, and that's not relevant here. Could this patient have a transplant? Because transplant-associated microangiopathic hemolysis is an important entity that we can suspect up front. Is there a reason to suspect drug-induced? So drug would be things like quinine, which can actually occur from tonic water ingestion. And then is there a valve issue? So a valvular issue can certainly come into play, but I don't think any of those are at play. Patient's not pregnant. There's no transplant history. There's no drug history, and there's no valve issue. And so I think this is TTP until proven otherwise. And the plasmic score is a great score that will help you determine whether you should initiate empiric therapy before the ADAM-TS13 comes back. I think what's unusual for me, just to say it out loud, is the height of the white count. And the height of the white count may push you to wonder whether this patient has DIC, but that appears unlikely in the absence of marked coagulopathy. It also is a reminder that TTP is a chronic disease that is triggered by superimposed processes, including infections. So I wouldn't rule out the possibility this patient has chronic TTP brought to light today by an infection. It's also really important as you're thinking TTP to look for the two most common chronic triggers, which is an HIV undiagnosed or diagnosed, and lupus. So patients with those two conditions are much higher risk of developing TTP. So what would I do in real life? I think plasmic score, hemonc, ADAMS-TS13, empiric plasmapheresis probably, and then think about HIV and ANA testing as a start for those conditions. Umaima, before you tell us the answer or your thoughts, how are you feeling now?
I've got way calmer than when I started 30 minutes ago.
What do you think changed?
Yes, that was fun. Thank you so much, guys. You all have been supportive, and I've been reading the chat. Thank you so much. It really made a huge difference.
Yeah, I think it's hard. It's hard. Also, probably hard for you not to consciously or subconsciously feed back the fact that the conversation that you are creating is one that is very rich and full of learning. You can see that in the chat, and hopefully you can see that in the joy and angst that Leah and I have right now. So we'll hand you the mic to take it home.
Yeah. So the last lab that we have is ADAM-TS antibodies. They were 120, so definitely high. And the final diagnosis is TTP. You guys nailed it.
Leah, what do you think?
Wow, I think I'm just in awe by this case just because I didn't expect it at all to be a hemolytic cause. And I have to say, Maima, I think the presentation was so good because it was clear, and I feel like even though you didn't use many words, it's so rich, and I think that makes a really good presentation as well. So thank you so much for sharing that. Yeah, I think there are many things that I will go back to from this case and be like, okay, I would think I would have to learn about thyroid storm and bilirubin and see how. I think one of the things is how much neurologic symptoms or how acutely does TTP present? Because from the first description, it didn't seem so bad, but then maybe it would have been different if we were with the patient. Yeah, but thank you so much for sharing that, and thank you, Rabih, for discussing with me.
Yeah, I thought you were masterful. I think you were authentic in the whole way, and just because the outcome turns out to be that 5% that we talked about doesn't mean that your thinking was wrong along the way. It's just it's always a probability analysis, and you can't let the outcome overemphasize your thinking. But I do think that now, like I said to you, I think if it turns out to be indirect, we'll come back and we'll reassess. And I think that if you ask yourself, what is one cause of acute hemolytic anemia and confusion? I think the one cause to always think about is TTP. So for me going forward, I think if I hear jaundice and confusion, I'll be like, yeah, it's almost certainly hepatic encephalopathy, but I have to make sure that this is not TTP. And while I wait for the 1 hour that the labs come back, I will use the heart rate as a clue, because the heart rate's usually not elevated in patients with liver disease. And I overemphasized hyperthyroidism, but hemolytic anemia is probably a little bit more likely to cause a tachycardia, acute hemolytic anemia, than it is hyperthyroidism. So at the end of the day, do I think it is achievable to suspect TTP from the get-go? Yes. Do I think it is wise to do that every time? No. You have an hour, the labs will come back, and then you'll be much wiser. But it certainly, I think the clues were there, as we suspected. But the mistake to make is to overemphasize those clues and forget to think about liver next time. It's definitely not the right way to do it. Well, this is superb. I'm curious what reflections you have and what thoughts you have from this case.
I think we also followed the same, like chain of thoughts as Leia. We were thinking liver, and we were very surprised when we saw the CBC. And like we started like calling a radiology. We thought about doing an abdomen CT. And yeah, it was a surprise for us too. Unfortunately, the patient was transferred to another hospital for plasmapheresis. So I don't know the outcome, but I hope he made it well. He made it he made it.
Thank you, Emma. I really appreciate it. And yeah, I'm glad it's an honor that our thoughts are aligned with yours. That's a treat. Well, Emma's case was superb. We'll also have something to celebrate, which is Laura's return to the teaching points on VMR. Take it away, my friend.
I want to say, Emma is calm, but I'm super nervous. First, because of the case, I loved your presentation. It was amazing. And your discussion, it was superb as always. But I'm nervous because you talk too fast. And I was like, I need to get concise information, and it's hard. And I'm already just talking too much. Okay. Let's go. So for the teaching points, we started with jaundice and the time course, which was acute / subacute. And so we would think about the past medical history. Is it related to liver disease already? Or did he take the medication for the fever? And then the jaundice started, and then we could think about medication-induced liver injury. And then is it cholestatic? Is it hepatocellular? And about the pattern, is it direct or indirect? And we started thinking that the indirect would be associated with hemolysis, and that the patient would appear acutely ill. And so he would have cardiopulmonary deficiency. And we started thinking that it was a direct pattern, but he also had confusion. And so we thought that it could be an encephalopathy related to liver injury. And then we highlighted the importance of the physical exam. Evidences of chronicity would be abdominal distension, hepatomegaly, and the capillary And also we got the severe tachycardia in the physical exam, but that made us think of extrahepatic disease complicated by cholangitis, for example. Why? Because intraparenchymal diseases usually have no systematic involvement. And then we got to the conclusion that it could be a non-hemolytic cause of indirect hyperbilirubinemia. And so Rabih told us about the thyroid storm as a possibility, which I also didn't know about. And then we got the labs, and the patient had acute anemia, which was evidenced by the tachycardia and thrombocytopenia. And so they could be causing each other, they could be related in 3 ways: the environment and the blood. And so microangiopathic hemolytic anemia would be a possibility, or attacked by antibodies, autoimmune hemolytic anemia, or a bone marrow issue. And so the patient had, the smear had schistocytes. And so we thought about the microangiopathic hemolytic anemia, but the jaundice and confusion, from now on, we're going to start thinking of TTP, which ended up being the patient's final diagnosis. And that's it.
I think I have to talk even faster to be able to stump you. How's that? Thank you so much. Welcome back to VMR, crushing the teaching points as you did before. And what is that? Is that your cat next to your name? Is that what you did?
It is a cat.
All right, y'all. See you next time. Thank you, Emma. Thank you, Leah. Thank you, Laura. And thank you, David, for scribing. See y'all next time. Bye.
Bye.